presenting. Will it make okay, we are recording. That's good.
Yes, and it also makes a transcript, which is really also
helpful.
Awesome. Yeah.
Sweet. Okay, let's see if I can get the share screen working correctly. Can everyone see my screen?
Yes.
Okay. So everybody, welcome to the Quality Improvement Committee meeting for May 29th. I'll go over the agenda now. First, we're going to go over the minutes from last meeting, which we used AI for that. So if you identify any issues, other than the Zoom link, we will correct that. Then we will go over some excess log data. I do have it on our agenda to go over CANs and PSC 35. However, I'm kind of working on a report to have that data. So I anticipate having a bit more to discuss in the October meeting. We will go over some inpatient IMD residential program data, some process TAR data, and then we'll discuss notices of adverse benefit determination. We'll talk about county and contract provider certification recertifications, which is basically part of our credentialing program. I will briefly discuss some audits and reviews that either have occurred or in the process of occurring now. I wanted to highlight, this agenda is slightly different than the one that was sent out because I did want to go over our QI work plan, which we recently finalized. And then we will go over consumer participation in services, system planning, and how that impacts our QIC committee. And then we'll talk about our next meeting date and discuss any action items. So the next slide will be our minutes. Did everybody receive a copy of the minutes? Do you want me to pull them up for a visual? Probably would be a good idea, huh? I just moved them over into the view screen. Can everybody see them?
Yes.
Yes.
Okay. So I'm going to skip over the quick recap. I assume you all can read, but we can talk about the next steps. We did some discussion involving corrections for QAPI slides that were utilized in the last meeting. We talked about implementing changes to improve psychiatry appointment scheduling and follow-up on no-shows and cancellations. Let me see if any of those folks are in this meeting now. I don't think they are. So I will have to give you an update in the next meeting on that, unless Elise has something she'd want to share in that regard. I did discuss utilizing crisis call statistics in the next meeting, but I think we talked about bringing those into QAPI. So once we get those statistics within QAPI, I'll utilize them in this meeting going forward with October. Rob was going to review the data tracking for psychiatry requests to ensure accurate representation of new requests. Marty was going to present a month-by-month comparison of TARs for the current year versus the previous year at the next meeting. I don't know if he has prepared that yet, but I do have some TAR data to go over in this meeting. Savannah and April was going to address findings from the Omnicare review, particularly regarding medication destruction practices. And I believe we did have a meeting involving that, although I don't believe Savannah and April are here to discuss that in this meeting. I do have some data involving no ABDs and where we are with that. However, I think I need to work on the reports for the timeliness of those no ABDs going forward. The detailed synopsis of chart reviews, we actually had a slight pause on some of the chart reviews for this meeting, well, for this quarter because of other important projects that our QI chart reviewer was working on. So she will be resuming those chart reviews and they will be including our DMC ODS chart reviews as well. So she's kind of expanding her scope of chart reviews going forward. And then Ken is going to provide some consumer perception survey results at this meeting, which he did provide. And I think that covers everything. Did anybody find any other issues besides the Zoom link or the Teams link on the minutes that need correction? Don't everybody all speak up at once. Rob's shaking his head, so I'm going to take that as a no. So we'll go ahead and go back to the slides. So looking at the access log, we did a quick review of the request by referral source. So you can see that our DMC ODS request for access, every single request for access is supposed to have a timely access data tool entered. And those data tools are what I utilized in order to capture this data. So it looks like Crisis made 5 referrals. One came from the Medi-Cal Managed Care Plan. That would be Carillon or Partnership Health Plan in our case. 2 came from other county community agencies. 8 came from probation parole. The majority of them were self-referrals, and then there was 11 coming from social services. For our mental health, non-psychiatric access records, we got some from Crisis, we got some family members, some from the jail prison, 11 records for other, so that was, could be a friend, it could be someone in the community. Probation parole sent over 3 referrals. The school sent over 1. Again, the majority is self-referrals, and then we did receive 1 from social services agencies. And then we had 22 self-referrals for mental health psychiatric, which constitutes the entirety of the referral sources. Does anybody have any questions on this slide? It's kind of hard to present and monitor the chat. So if anybody is willing to monitor the chat and just mention when we have a question that needs to be addressed, I'd really appreciate it.
I've already been doing that, but so far we got nothing in the chat.
Sweet. Okay.
I'll let you
Rob
know
had
if I
this-
see anything.
Thank you, Patty. I appreciate you. She's multitasking. She's actually running the recording and monitoring the chat. So thank you, Patty, for your sacrifices.
Very welcome.
Rob?
No, I was raising my hand to say I would do it, but Patty already is doing it.
Thank you. I appreciate all of you. Let's go to the next slide. So when we talk about timeliness metrics for the access log, I just want to, yes, we will get copies of the awesome slides. Thank you for that compliment on the slides. I wanted to go over the timeliness metrics just to kind of solidify that in your brains, because we don't operate with these timelines just off the top of our heads, and it has expanded since we went DMC ODS. So when we have an urgent request and it doesn't require prior authorization, we have 48 hours to address that. If it's an emergency, we have to deal with it immediately, obviously. We call those emergent, and the ones that could take up to 48 hours are considered urgent. And perinatal and IV drug use, individuals with those needs are considered urgent no matter what. For MAT, our opioid treatment program, we have 3 business days from the request in order to address that, and they're also considered urgent. And then the urgent request with prior authorization, so those types of services that require prior authorization, we have up to 96 hours to authorize those or deny them. A routine request for services, we need to give the individual an appointment within 10 business days. A follow-up appointment to a previously attended service, so that would be like the second appointment. We have an additional 10 days from that point. So from the point that they were seen on the first appointment, we have another 10 days in order to address that follow-up appointment. And then psychiatry routine is 15 business days. If it's not routine, it would be lumped into the urgent category. How we're doing in that area for mental health it looks like, we have some room for improvement. For one team, we had 14 days, but most of the other areas were meeting or exceeding the timeline requirements. So I'm seeing 10, 9, 6, 3, that's all good numbers. And that's from the first request. And then the days from first follow-up is also within the standards. Does anybody have any questions on this slide? Okay. So the total count of access requests, I just thought this was kind of interesting information, is it's split almost 50-50 with mental health and DMC ODS, which means that, that's really good because we're logging our requests for our timely access data tool. That's actually kind of a manual requirement that the caseworker go in and initiate a timely access data tool on a request for service. So that's good to see that they're being logged consistently. The majority of the requests appear to be DMC outpatient timeliness, at least that's the total request, but then you have mental health non-psychiatric and mental health psychiatric. And the non-psychiatric is 39% and the psychiatric is 16%. So I wanted to throw this slide in there because I did put it on the agenda, but I will go over CAN's PSC 35 in the next meeting. Like I said, I have some reports being developed and I want to show those off in October. Going to process TARS, there was 21 hospitals and it impacted 279 beneficiaries over 3,587 days of service. So the average days of service for each request was 12.85. The 4 hospitals, when I say top, we don't mean top specifically as in terms of quality. We mean the most utilized hospitals are Aurora with 63 beneficiaries and 874 days of service, followed by Adventist Health, BHC Heritage Oaks, and then Sutter Center for Psychiatry. The most utilized short dwell hospitals appear to be the same, but with different numbers of beneficiaries and different dates of service. And then the top or the most utilized Medi-Cal paid hospitals are Aurora, again on top, and Adventist Health, then Sutter Center, and then Adventist Health St. Helena squeaked in at the very bottom with 16 beneficiaries and 118 days of service. We utilize Kepro, Accentra, which is a partner of CalMesa, a third-party organization that supports concurrent review and RTARS. And this is another data summary showing the breakdown of the different hospitals. It shows that, our average length of stay is about 10.26. And this is for last fiscal year. 7/1 of 24 through 5/19 of 25. So not a whole fiscal year of data. So that's why some of the numbers are slightly different from the previous slide.
Hey, Vanessa,
yeah.
I'm sorry to interrupt you. We have a question in the chat. What does TAR stand for?
Treatment authorization request. Thank you for that question.
Thank you.
We need to get away from those acronyms, but it's really hard when you got to fit it all in the screen. But our minimum length of stay average is 1. Our maximum length of stay average is 76. So you can see that our individuals are spending a lot of time in these hospitals. And it's unfortunate. I don't think I have a slide devoted to the cost, but maybe in the next meeting I can bring that up because it's interesting to see the charges that are associated with those extensive lengths of stay in these hospitals. So for our legal status slide, conservatorship, we had 5, foster care 1, voluntary 3, and 5150s are 168. So that's the majority of these legal status requests. And then we had some 5250s on a 14-day hold, only 2 of those. But the minimum length of stay average is 1, the maximum length of stay is 76, and the average length of stay is 21.1 days. Does anybody have any questions? No. Okay. So this is a slide devoted to the insurance based on or categorized by age. So for indigent, that is without medical insurance of any kind. We had 7. Did I get that accurate? Somebody correct me, please. Indigent.
Correct. Total.
Okay, so without insurance. Indigent means without insurance. Okay.
Correct.
So the total is 7. We had 6 adults, 1 youth. The average length of stay is 13.5. And the maximum length of stay is 31. For Medi-Cal, that's where the majority of our folks are. We had 166. Most of those were adults, 120, 46 youth. And the average length of stay is 10.92 days. And then we are serving some individuals with private insurance, only 3 so far, with an average length of stay of 7.75. Interesting to note that the average length of stay is much lower for private insurance versus Medi-Cal. Makes you kind of wonder if Medi-Cal is the higher payer, or if it's associated with additional needs. If anybody has any insight on that, I'd be happy to hear it. If not, I'm going to go ahead and transition. This is another breakdown of indigent, Medi-Cal, and private insurance showing totals. So I'm going to go ahead and skip that slide. And then we only had 1 appeal and it was overturned. So we don't get a lot of appeals. That means, I assume that means that Accentra Kepro is doing a pretty good job. They're not getting a lot of requests for reconsideration of the benefit determinations. For no ABDs, we had many no ABDs issued. And interestingly, I think this is the first time I've ever seen it where the majority were termination notices of adverse benefit determination. I anticipate, I can only presume, but I anticipate that this is a result of caseload review and cleanup, because another good question, Allison, a no ABD is a notice of adverse benefit determination. So when the department initiates an action that could be considered negative to the client, terminating services, taking too long to authorize services or deny services, or shifting them from one delivery system to another. So when we move them over to partnership health plan because they no longer meet our level of care, or they were screened and they determined not eligible to our level of care, then they would be eligible to a notice of adverse benefit determination. That notice of adverse benefit determination is just a letter that identifies the action that the department took and provides some appeal rights to the individual if they feel that that action is wrong. And there's strict timelines involving response on the county's part, involving responding to those timelines. So the majority was 282 terminations. Interestingly, we only had 5% timely access. That's either an indicator that we're doing a really good job with our timely access, or that we're not, where maybe there's an issue with logging them. So we'll have to dig into that a little bit further. Usually the timely access, no ABD is the biggest grouping, but if we're doing really good on our timely access, which appears that we are based on the access stats in one of the previous slides, that could be accurate. The difference between a denial and a termination is that a denial is when they're not currently in receipt of the service. They're just applying for something. Maybe it's a brand new request for service, and we've determined them not eligible, and we didn't have enough information to move them into another delivery system like partnership health plan. Or a termination is when they're actively receiving services from us and we're terminating for some reason. And that termination, maybe they're failing to cooperate and we don't have enough information to move them to a different delivery system, something like that. Or maybe they ask to withdraw and then, or terminate their services. In that case, we would send a termination notice of adverse benefit determination. Does anybody have any other questions on this slide? Okay. So credentialing and recertifications, and I see now that I spelled recertifications wrong. My apologies there. I will fix that in the final slides. But we did have several providers that we're going to actually remove from our master provider file because it looks, and the master provider file is a file that DHCS maintains at the state level with us to say, identify who we're contracting with to provide services for our patients. And so I did remove those from this slide because I didn't want to muddy the waters per se, but we, for mental health, we conduct recertifications once every 3 years. And this shows kind of a timeline grouping of when those recertifications are due. It looks like we're overdue on Victor treatment and Stabler Lane, although I am aware of the fact that we did conduct reviews in July of 24. We're just not sure if those reviews are will work in place of meeting this requirement. We have to do that validation on our end. But either way, we plan on conducting these site reviews here in the next few months. We have one that's coming up due in May, North Valley, and then several that are due in July and beyond. But I believe Marty's already working with the schools on some of these already, so they'll probably disappear from this timeline in the next month or so. Does anybody have any questions on this? Okay. This is our DMC ODS site reviews schedule and the noticing dates, the dates of projected visits, whether or not the site visit was completed at the time of this report. And then when we actually complete the review, we have to notify DHCS. And shows that we have 1, 2, 3, 4, 5, 6, 7, 8 that are still pending for this year. We're just kind of getting started. Generally, we do these site reviews at the beginning of the fiscal year. And so if we were to do this slide in October, we'd probably have a lot more completed. This is like the heavy renewal recertification period for us. Does anybody have any questions? Are we missing anyone on this slide, Ken?
Nope, because we have the new Archway Recovery Services, both locations, Napa and Fairfield, along with the RCS outpatient, the home project.
Wonderful. Okay. And we do have several more providers than before. I mean, New Life is new to the this last year. And with our expansion to DMC ODS, it has maybe it hasn't expanded the total number of providers, but definitely the expansion of services and the scope of our reviews.
Yeah, June will be a busy month.
Yeah. So quick review of the audits and reviews that are going on or have gone on. Two big ones are the external quality review and California mental health combined NAV and MMV audit. I added HEDIS here, and I would have to look up what HEDIS means, but basically it's a bunch of outcome measures that measure how well we're doing in responding to service requests from different areas like emergency rooms and how we're doing on I want to say like opioid treatment consistency in services, individuals sticking with the program and succeeding in their treatment plan. I believe we are partnering with Cal Mesa to calculate our HEDIS measures this year and last year. So we have those reports. We provided them to the external quality reviewer, and they were I believe that Cal Mesa is working on getting certified by the NCQA standards, which is like being credentialed at a higher level. And our triennial review, we recently went through, we only had 2 findings, and that involved Allison with the acronyms. I'm not exactly, Rob, do you think you could look up what NAV and MMV?
Rob has
stands
taken
for?
to the waters. He's using frustrator. My apologies.
I know it has to do with our HEDIS standards. And it's calculating where we are on those outcome measures. But maybe Rob can give us an update while I finish discussing the triennial findings. So yeah, so we need to beef up our utilization management program. We need to be monitoring arts and carts, adult residential treatment, and crisis residential treatment. We are working on a game plan for that. And then we also needed to beef up our ICC, IHBS screening and referrals. And I'm gonna Google ICC IHBS because I don't remember the acronym. Elise, if you happen to remember. So intensive care coordination, which is targeted case management services for children, and then IHBS is in-home based services. And that's not all. We also have an mental health block grant cap, which is our cap submission is due for evidence is due by July 31st. We're going to be providing our monthly meeting minutes for a new committee meeting for the mental health block grant that we've developed. We're going to provide documentation of our goals and measurable outcomes for each program, function, and activity for fiscal year 24-25. The goals that we're going to be working on is 75% of individuals identified as possibly meeting criteria for the early psychosis intervention program will be seen for screening and or assessment within 2 weeks of referral. This involves identifying our early psychosis intervention individuals, like the caseload of early psychosis intervention, as well as identifying the referrals that were made. So there's a good bit of work on the back end to beef up the logistics for this tracking mechanism. But we're working on that. We do have the caseload identified in our special populations, and we are working on identifying those referrals. Additionally, we will have qualified trained professionals employed or contracted with our department, provide psychoeducation and CBT interventions through the delivery of individual and group formats for at least 50% of individuals enrolled in an early psychosis intervention program. We had to add a tracking mechanism in our electronic health record in order to identify what services are related to cognitive behavioral therapy interventions. And now we're developing the report to generate data based on those selections. So more to come there. And then qualified trained professionals employed or contracted with us who are knowledgeable in early psychosis intervention will identify and provide targeted outreach to a minimum of 2 community groups within a year. And I believe our early psychosis intervention program team lead, Gina Hutchins, has already been working on that goal with our schools. Does anybody have any questions on this slide? Okay. So our quality improvement work plan. Oh, thank you. Network adequacy validation. Ken, that's what NAV stands for. And that ties in with our network adequacy submission and our 274 submission, which is basically a mathematical formula that identifies how many providers we have available to provide services to our beneficiaries in the county of Lake. So that validates whether or not we have sufficient providers to provide those services. So on our website, I provided the link here. Our QI work plan was finalized this month. Pulling it up, I'm going to do it just a quick review because it is looking a little bit like we're about 40 minutes in, and this is a lot of data. So I know that can get taxing. But going to the charts, how we met on our goals, that's what's most important to us, right? You know, the goals that we set for ourselves. So we're monitoring the timeliness of their request for routine outpatient mental health services to ensure accessibility. And this last year that we evaluated, 90% met the goal, and that's up from 89.2% in the previous 2 years. So that's a pretty good improvement, only moderate improvement, but 90% is a pretty good number. So I think we're doing pretty good there. We will continue to monitor it, and timeliness will always be a critical factor for our service delivery. We also want to engage more transition age youth. That's what TAY stands for. And we did. We succeeded in that goal. We went to 17.43 services per TAY client, which is up almost a little over 2 from 15.2 services in the previous 2 years. Thank you, Christina. I agree. It is wonderful. We're doing really good from before. Ensuring timely access to a medication assessment. And I want to add the caveat that some of these numbers are pretty bad for previous years. But that very well could have been a data issue because our previous electronic health record, it wasn't very easy to identify when someone is receiving an on-time medication assessment. They kind of got lumped in with the rest of our mental health services. It was hard to pull those out. So part of this may be just better data tracking and access to better tools to track that information. So I don't think that just because only 10% met the goal in 2 years ago that necessarily means that we were doing not subpar quality service. I think it was an indicator that our system was out of date at that time. And now that we have a newer system, we're actually meeting 156 out of 164 requests. And so 95% have met the goal for our individuals being provided a medication assessment within 15 business days, which is the state standard. So that's fantastic. That's good. It means that our people are being reviewed for their needs and provided medication on a timely basis. And we'll continue to monitor and improve in that area as much as we can. For specialty mental health services, patients offered a follow-up service within 10 business days of an initial service appointment. So mind you, this is the second appointment, not the first appointment. We're struggling. We were in fiscal year 23-24, only 29% met the goal, and 49% met the goal in fiscal year 21-22, and we did really good comparatively in 22-23. So we'll have to kind of dig into the data. I'm sure Rob and I can go over these metrics and see if there's anything that we can identify that would help us figure out what's going on here. But we definitely, and this is consistent with what I observed in our HEDIS metrics reports as well. We struggle in this area. And it could be a tracking issue because this does require going, like the way that logistically, the way the timely access data tool works in the system is you create it whenever there's a new access request and you're talking to the client, you're on the phone with the client, you're asking the demographic questions and all of that. You go and enter this form. That captures the information on the initial appointment. But then after that appointment, you've got to remember to go back into that form and enter the data for the second or follow-up appointment. So there might be some data issues there. But we're going to have to dig into it and figure that out because this 29% is much lower than the previous year. So, and it's consistent with what we're getting on our HEDIS reports, so that's not good. Excuse me. We were looking to increase our FSP program enrollment for clients of all ages, and we succeeded in that goal. Only 4.6% of our individuals in 21-22 were receiving FSP. It went down to 3% in fiscal year 22-23, and then we doubled that in 23-24. I know these numbers are still pretty small, but FSP or full service partnership represents the core group of individuals with the highest level of needs, outside of maybe the folks in the hospitals. But these folks are provided case management services and maybe housing or other types of supports to wrap around them and support them in succeeding in the community as much as they can. So so we doubled that. That's good. And we continue to work on improving our FSP determinations accordingly. So denial rates, we were tracking denial rates to ensure compliance with timely and accurate billing standards. We actually want this number to go down, and it did, at least from last year. So calendar year 2024, we only had a 2% denial rate, so that's fantastic. And that is down from 3% in the previous year. And if we're thinking about the immensity of the claims, we're talking 46,357 claims. And only of those, 1,026 were denied. We still are at the top of California in terms of standards on billing denials. Our fiscal team handles billing directly. We don't contract out for that. I think we do for like reporting on one thing, cost reports, I believe, if that may or may not be true anymore. But our fiscal team handles a lot of this in-house and they do a great job. And this is a representation of that fantastic work that they do. To increase productivity, we're looking at improving the percentage of billable services. And in order to determine this standard, we expanded to include our contracted providers, and we're looking at billable minutes versus the FTE that we're reporting for that individual. So we look at the service reports that identify the billable minutes that each provider within our network is billing and actively receiving payment for, versus the total FTE that we're reporting on our network adequacy. So what we're telling DHCS is available versus what they are billing. And often there is some administrative work that we don't get paid for. It's not considered billable. So it is very reasonable to never have 100% in this area. The goal is to get it that, 43.9% up, and which we did in fiscal year 23-24. And we are actively working. I know that our clinical deputy director has instituted a lot of training and efficiency programs to support staff development to ensure that our billing productivity goes up even further in the next year. I'm actually really excited to see the stats the next time we run these reports. So CalAIM training. We have CalAIM is It's a regulation that came through in 2021, but it's so major, it's so huge that it's an expansive in its scope that it kind of dominates multiple years. And it required that in order to receive incentive funding for certain things, we would need to expand our training across our contracted provider network, which we did. And, you know, in the first year that we rolled this out, fiscal year 22-23, we only had 8% who actually, you know, took the trainings. And the next year we actually had 74%. So we actually implemented CalAIM training into our onboarding. And as you can see, we made some massive improvement there. And we will continue to include CalAIM as a major subcomponent of our onboarding and ongoing training. So Allison had a question about why the claims doubled in the previous year. So let's go back to that slide. And I don't know the answer to that. Is anybody from fiscal here that can maybe address that question? I do know that CalAIM came out about this time, and that expanded our billing, what is allowable for billing and the services allowed to us to bill for. So that could explain why some of these claims increased. It could also be that the data is more accurate in terms of a lot of our claims going through the electronic health record in our reports. Like a lot of our providers, when we migrated to Smart Care, started billing in Smart Care directly versus invoicing us. And those invoices never made it onto our Smart Care billing report. So that's possibly why. Does anybody else have any ideas? I mean, having more claims is good because it means that we're drawing down more money. And I think that that's consistent with what we anticipated when CalAIM rolled out. Because they provided a little bit more flexible documentation practices and allowed us to bill for things that we'd never built before. So this year is the first year we've included some DMC ODS goals, which is really exciting. Oh, thanks, Monty. Monty is our senior analyst in fiscal, and she said we nailed it. So that's good. So for DMC ODS, we were looking at offering an initial assessment appointment within 10 business days of request. And we did pretty good. We got 88%. So 337 out of 381 met that criteria. And that's a pretty good number for a first year rollout of a new expansive program like DMC ODS. So I'm really excited about that metric. And I look forward to seeing additional increases getting us over that 90% in the next year. The next goal is about retention of DMC ODS clients. So DMC ODS is substance use disorder services. So our clients sometimes are voluntary. The idea is to keep them in treatment and get them to, you know, succeed in whatever goal or endeavor their and their provider come up with for remedying those needs. And it looks like our retention rate, at least this is our baseline year, this first year, is 43%. So we have some work to do in that area. We had 1,271 client requests and you know, much less than half, 551 ongoing clients. So we'll continue to work towards increasing the percentage. We do want retention to go up because we want people to stay beyond 30 days for substance use disorder services. Does anybody in the substance use disorder service world want to explain why retention is important for this area? Rob? I just don't think that they've identified that 30 days is good enough. that we want to see people at least receiving a service after 30 days. And that's what this goal is geared towards.
I'm not sure what they are looking for as an outcome in terms of why it's so important for them. I would assume it's trying to engage them more so that they do stay. It was an odd number in request, like 30 days or more. Is Amber on here? Would Amber know?
Hi. I'm sorry, I kind of missed the first part of what you were discussing, Vanessa.
Our goal of 50% retention for new DMC ODS clients. Where the question that was posed to us is, why is it important that we want them to receive at least one service after 30 days?
After 30 days?
Yeah.
Okay. Okay. So sorry, my brain's going a million miles an hour and I'm trying to slow it down to
It's
provide
okay.
a clear answer.
This
So,
was
I
a tough
mean,
question.
well, it differs based off kind of who's asking, right? Like if this is from who, so this is a question posed. Okay. Well, I mean, retention is important because it shows that we are engaging people in services and so that they can have some meaningful and measurable progress in recovery. If we are only seeing individuals within a 30-day period, then that doesn't necessarily show that we are building rapport and engaging people in long-term recovery.
Yeah, because alcohol and drug recovery, it's not a one and done cure all condition. I mean, just like mental health, there's episodic nature of the needs, and I guess the data supports that people just don't get cured in 30 days from these. It's an identified need. We want to keep them in longer than 30 days.
Yeah, absolutely. I mean, individuals with acute severe substance use disorder who kind of need to stabilize, that can occur within the first 30 days, but long-term measurable progress continues, for a lot of people up to a year afterwards for sustained recovery.
Thank you for that. We do have another question from Allison. How can we increase retention? So what's our goal? I know that we really didn't elaborate much because I think in particular this goal, these were brand new goals to us, and I think we're still kind of solidifying our plan. But what's our plan for increasing retention this year?
Well, I'm not sure if if retention is really captured in this report. Does this report include our contracted providers?
Yes.
Or only it does?
Yeah. We're 551 ongoing clients. Does that?
Yeah, it does.
Okay,
Yeah, okay.
good. I mean, the plan was to include our contracted providers, and we did incorporate that in many of our other goals. So I assumed that it was applicable to this one, but thank you for validating that.
Yeah, okay. So how we can increase retention is to really ramp up and increase our care coordination, peer support, and recovery services.
Okay, so that's what we'll be working towards in the upcoming year. Thank you for that, Amber. So the next one, and I want to throw the caveat here that this is I feel like this is a data issue based on seeing this metric in multiple different types of reports. our goal was to increase access to DMC ODS services for Spanish-speaking clients. And our baseline year, we identified only 4 out of 803 individuals, or 1%, were identified as Spanish-speaking. And I think that figure is not accurate. And it could be related to the migration from the one electronic health record to another, because some data elements from our previous electronic health record, specifically demographics, didn't migrate over. So we've been doing a lot of caseload cleanup to identify who is Spanish speaking and who isn't, but 1% doesn't accurately represent our population. Amber, do you think can you speak to this at all? What have you seen in the caseload? Like,
Yeah, I think it's a training issue and a data collection, because I've just myself more recently even discovered that there is an option in Smart Care to indicate that they're Spanish speaking only, which also creates alerts within the EHR that I was not aware of, and I've just brought to my staff attention. However, I think that perhaps that can be revisited at some point, Vanessa, maybe in the clinical office hours.
yeah, we actually, I love that idea. I think we're gonna do a notice of adverse benefit determination training on our June 12th office hours. So I think we'll sneak in a few additional points, maybe discuss how to flag a chart that is Spanish speaking or other language, in order to help with that data tracking issue, because I agree. I think our population, I mean, I'm seeing requests much more than 1%. So this is not accurate, but in our next year of data tracking, I anticipate we'll be have much more solid footing in terms of numbers. And that completes our QIC. I'm sorry, a QI work plan topics. Let me go back to our PowerPoint slides. We only have a few more things. So consumer perception survey results. We only have some very minor preliminary results right now because we just completed we did another consumer perception survey this month. Just did a whole week of survey, but that was for 2025. And we don't actually have any qualitative insight yet from the 2024 data. It usually takes a while because DHCS utilizes a third party who processes the information. We get the results. And right now, these are our preliminary numbers. Maybe in the next meeting, we'll have more qualitative insight. But here are the counts. For the family survey, we got 9 back that were English. For the older adult survey, we got back 18 total, with 8 being English, 10 Spanish. Interesting that we had more Spanish than English. For the youth survey, we got back 20 total, which a quarter of them were Spanish. And then for the adult survey, we got 1 Chinese, 47 English, and 15 Spanish. I love the diversity in terms of the different languages that we're capturing here. The numbers are still pretty low. If you look at our mental health caseload, talking 2,500 people-ish. So very low numbers, but these surveys are not the most convenient questions for people to answer. It's just kind of dry questions. Can you think of any of the questions on the survey just to give somebody an idea of what our clients are kind of answering? No? Okay. Well, it's basically
usually it's on a scale, like, do you strongly agree? Do you strongly disagree? Yeah, how do you feel about services being provided? Things of that nature.
Thank
And
you.
it's usually about 30 questions long.
Yeah, so a lot of questions. I mean, I don't know about you, but if I'm being tasked with a 30-question survey, that's a substantial sacrifice of time. So future improvements could be less questions. Unfortunately, we don't dictate the questions themselves or the amount of questions. And the surveys are offered in Spanish and other languages. As you can see, we received one back that was in Chinese, so that's fantastic. Rob, you have your hand up. No, you don't have your
Yeah,
hand up.
sorry. Somebody was blocking my microphone. I had to get it out of the way. Oh, criminy. Oh, so shortening that has been raised with them multiple times, and they're like, it's not going to get shorter. They're just adamant that it will not be a shorter survey. So they're okay with what us and other counties are producing. We look at it and we're disappointed when we got 100 surveys, but like you said, when a lot of people, when we show them the survey, they're like, yeah, I don't have time for this. So there's not much we can do.
So
Plug along.
other ways to accept information from our clients, although we have to be really kind of balanced with our requests because we don't want to hound them too much. But we could, we can initiate any kind of surveys to determine our effectiveness and the quality of the services that we're providing. And while this is the one mandated survey by DHCS that happens twice a year, or is it once a year now? It used to be quarterly.
Two different
but
surveys.
Two different
First in the
surveys.
spring is the mental health, and then in the fall will be the SED survey.
Okay, so it's once a year for mental health and once a year for substance use disorder services. So this is the one mandated survey by DHCS, but we also have other opportunities. We have, an opt-in list that we can utilize to do quality improvement evaluation and so forth. And obviously we would utilize less questions in order to capture as much response as possible, be very careful and balanced in our approach. The next meeting that we have for Quality Improvement Committee is October 30th of 2025, and it looks like we're getting towards the end of our time anyway. Does anybody have any questions before we close? This was a pretty decent sized group today. Henry, you have a question?
Not a question. I just wanted to say for the early kind of post survey count for this year for CPS, we already have 99 responses. I do not know if there are any more in the mail or in the hands of caseworkers or the like that have yet to trickle in, but we are doing well.
That is great news.
Yeah,
Thank
the
you
total
so
for this
much.
one was 110, so we're within range. We're within about the same range. Yes.
All right. That's exciting. I hope we also get, varied responses in different languages too. That would be really, I hope we can continue that. So we can get engagement from all of our people that we serve. Any other statements or questions? Okay, I'm gonna let y'all go. Thank you so much for your time. I appreciate it.
Thank you, Vanessa.
Bye.
Thanks.
Thank you. Bye-bye.